so for EKG placement, the first thing we need to do is prep the skin. Basically, we want to get the first layer of skin cells off so that the electrodes will stick better. The way we do that is either alcohol with a cotton swab, or you can take something with a rough edge and rub the skin where all of the electrodes are going to be placed.
So with that, we're going to do that at each site that an electrode is going to go on. We want to rough the skin so that we get the dead cells. Now remember that we need to have a clean and smooth chest when we do EKG placement, so oftentimes you will need to dry shave your patient, or if you have the opportunity to ask them to pre-shave prior to coming in for testing.
And make sure they're not wearing any lotions or oils.
Exactly.
Okay, so the next thing we're going to do is attach the limb leads. So if we were doing a resting EKG, in theory we could do the wrists and the ankles, but since we're going to possibly do an exercise EKG, we're going to do on the chest. Okay, so we're going to do right arm, right leg, and left leg. Okay, and then next we are going to do the precordial leads. So we'll start with V1 and V2. The way we measure that is V1 is going to be in the fourth intercostal space to the right of the sternum. So the way we're going to measure that is basically the easiest way is to take your pinky, put it right underneath the clavicle. That's going to be your first intercostal space. And then you're going to feel along with your fingers in between each rib. Okay, and you're going to do the same thing for V2. V2 is the fourth intercostal space to the left of the sternum. Okay, and then next we're going to go to V4. V4 is in the fifth intercostal space, the mid-clavicular line. So here is the clavicle. This is the mid-clavicular line. You're going to follow it down. Remember that our ribs go in a U shape, so the fifth intercostal space is a little bit lower. Also, if you are prepping a woman, you're going to go basically right underneath the bra line. Okay, and then next is V3. The site for V3 is going to be in a straight line from V2 to V4 halfway. So we're just going to find that and place V3. Once again, if you're prepping this on a woman, you're going to go straight underneath the bra line and place the EKG there. Okay, next we're going to do V5 and V6. V5 is going to be the anterior axillary line, okay, and that's going to be in a horizontal line with V4. So basically you're going to follow V4 over to the anterior axillary line, place V5. And then V6 is the mid-axillary line in the same horizontal plane as V4 and V5. So again, you're going to follow that around the body in a horizontal plane, mid-axillary line. Okay. Now that we have all of our electrodes placed, we're going to hook him up until we can get a reading on the monitor. So now we're going to attach the leads to the electrodes. They're all labeled, so you can just follow along. The longer ones will be labeled RA for right arm, right leg, left arm, etc.
One of the things that's really important is to try to not get your wires tangled up, to make sure that they're all unhooked, as I'm having difficulty with this one, unhooked and not twisted in each other, because it will help to cut down on the amount of artifact that's there.
All right, so next we're going to tape the leads so that they stay on and they don't cause any artifact on the monitor, especially if he's going to do an exercise EKG. So basically we're going to do what we call J-ing the wires, where basically you just loop the wire in a J shape and then tape it down from there.
Make sure that when you tape them down that you tape across the top of the electrode completely, and make sure that the wires are nice and flat when they go on, and will help them to stay on.
Okay. So now we have already attached the belt and he's ready for his exercise EKG. The only other thing that we may do is we could take another foam belt or a piece of tape and wrap around the top of his abdomen in order for the leads to stay in place, especially if he's doing something like a max VO2 test, because those leads tend to wiggle around a lot when he's doing vigorous exercise. But he is ready to go. The standard 12-lead ECG is a vital assessment tool relative to diagnosing various cardiovascular and pulmonary disorders. There are different approaches to interpreting a 12-lead ECG, which can be quite comprehensive in scope. Let us examine a few of the basic parameters used to quickly assess the 12-lead ECG for any abnormal criteria. We will review some of the more commonly used markers to interpret a standard 12-lead ECG. We begin by examining lead 1 and AVF to determine the axis of depolarization. It is normal for both leads to have a mostly positive QRS amplitude or prominent R wave in polarity. If lead 1 is mostly positive in polarity and AVF is mostly negative, consider left axis deviation. On the contrary, if lead AVF is mostly positive in amplitude and lead 1 is mostly negative, then consider right axis deviation. The precordial leads should reflect a mostly negative polarity, or S wave in V1, and steadily progress to a mostly positive amplitude or prominent R wave in lead V6. A positive QRS amplitude or prominent R wave in the anterior or septal precordial leads, V1 through V3, could be indicative of such variants as right ventricular hypertrophy, right bundle branch block, Wolff-Parkinson-White syndrome, or a posterior MI. We then move to leads 2 and V1 to screen for atrial enlargement. A notched or wide P wave in lead 2 coupled with a negative P wave in V1 may suggest left atrial enlargement, while a tall, slender P wave in lead 2 coupled with a positive P wave in lead V1 would suggest right atrial enlargement. A delta wave in lead 2 may also suggest Wolff-Parkinson-White syndrome. Our attention would then move to leads V5, V6, and V1 to screen for left ventricular enlargement. A very tall or prominent R wave in V5 and V6, along with a significant S wave in lead V1, would warrant ruling out a differential diagnosis of left ventricular hypertrophy, particularly if lead V5 and or V6 reflect ST segment depression or T wave inversion. Next, we must rule out any criteria that would be suggestive of an acute or old myocardial infarction. For example, a pathological Q wave, meaning a deep Q wave or QS pattern in any given lead or group of leads, ST segment depression, or ST segment elevation would warrant further evaluation in this regard. Finally, we must understand that certain leads correspond to the anatomy of the heart. For example, leads 2, 3, and AVF represent the inferior aspect of the heart. Leads V1 to V4 reflect the anterior portion. Leads 1 and AVL mirror the high lateral wall of the left ventricle, and leads V5 and V6 reflect the low lateral wall of the left ventricle. Again, to lend a comprehensive evaluation of the 12-lead ECG would include additional discussion and investigation. This is simply a concise overview of the process.